Hi, I'm Andrew Krakowski. I am the Chair of Dermatology at St. Luke's Department of Dermatology in Bethlehem, Pennsylvania, and I'm also the sole pediatric dermatologist in the area. Interestingly enough, I just happened to run into one of the people that were fundamental in terms of my career as a pediatric dermatologist. It started as a medical student at the University of Pennsylvania. I was going into pediatrics, always knew I wanted to be a pediatrician, had no idea that there was a specialty called pediatric dermatology. I had the good fortune of meeting Albert Yan and Paul Honig, who were at the Children's Hospital of Philadelphia at the time. They allowed me to do a rotation with them, which had not been done up to that point, and I fell in love with it. Went and did my training as a pediatrician and then applied to dermatology without understanding how hard it is to get into dermatology. 2 years later, after doing some research fellowships out at San Diego under Larry Eichenfield and Sheila Friedlander, I was able to work my way into dermatology, and from there I did a fellowship in pediatric dermatology with them, stayed on as faculty for 5 years, and then moved back east where I've been ever since. So the old adage that kids are not just little adults is played out and usually makes me cringe when I hear it, that and kiddo. But the truth is, we really are doing a service that nobody else provides. Understanding and focusing on a child from newborn through adolescence is a skill set that's unique to our specialty. Our own colleagues in dermatology are trained in theory from birth to seniority, chronologically. But still, we know that there's a need, even within that group, that people were going to reach out to us for help and for specialty services. Why? It's really hard to learn everything about everything. Breaking it into sections and giving pediatrics its focus and its own stage has been wonderful, both for the patients who benefit from that specialized training, but also for the practitioners who are trying to learn an ever-increasing fund of knowledge that is just impossible to master everything. So breaking it into smaller chunks, allowing us to have a subspecialty, kind of works for everybody. I've been pretty fortunate to have witnessed at least 3 miracles in my professional career. The first was the discovery that propranolol treats hemangiomas. Mind-blowing how that happened, just an amazing story, and changed the course of treatment for those birthmarks entirely. The second one was Dupilumab for atopic dermatitis and eczema. The idea that you could do an injection once every 2 weeks or once every 4 weeks based on your age and body size and have eczema vanish truly was a miracle. Most recently, the third miracle is sort of the class of medicines that we have now available for inflammatory skin disorders like psoriasis, where they're promising not 50% clearance, but 90% clearance, 100% clearance. That's actually now one of the goals, is to be totally clear. And we're seeing this. Now what I'm waiting for as a pediatric dermatologist is seeing those age indications come down based on continued safety data, efficacy data, proving that it's okay to use in younger and younger populations. Hopefully for those other biologics, similar to what's happened in Dupilumab, we'll see age indications down to 6 years, 6 months of age. Game changer. So right now in my home campus of St. Luke's Dermatology, we have a really interesting clinical trial underway that we started from scratch. We all know that a particular bacteria called Staph aureus, specifically methicillin-resistant Staph aureus, uses the nose or the nares as a place that's called a reservoir, where it sort of hides and lives. And it's thought that maybe that's a point of contact for spreading down to the skin and super-infecting, or at least colonizing, atopic dermatitis, eczema. Well, that's been the traditional way to think about a reservoir, the primary reservoir. Another possible reservoir are the skin products that the patients are using themselves. And I always like to reference Seinfeld. If you're a Seinfeld fan, you know the episode where you don't double dip the chip. So imagine you got a tub of whatever great moisturizing cream that you tend to use. You reach in there, you scoop out some moisturizing cream, you slather it on your child or yourself. You're picking up potentially some of that colonized bacteria and then reaching right back into the tub where you've potentially contaminated the skin product and turned that into a reservoir. The trial's been going on now for about 1.5 years, and we already have at least 10 patients where their skin is colonized with the same bacteria that were growing from their skin products and not being able to find in the nares as a reservoir. So it raises some interesting questions. Maybe might change how we do some skin hygiene practices down the road. I'm tremendously thankful to the Society for Pediatric Dermatology and Dermatology Times for relaunching the Don't Be Rash podcast in the form it is today. I really feel like it's going to become, hopefully, a vehicle for all of the membership to share with not only other colleagues within the society, but also externally, the public at large, topics that are near and dear to their heart. We can dive into a topic as deeply as they want to, and in the process, I know I'm going to learn some stuff. Hopefully, whoever's listening will also tend to learn. Don't Be Rash is unique, 100%, in the sense that it is the only current podcast to feature and focus on kids' skin conditions exclusively. There's nothing else like it out there. Trying to decide if I'm going to integrate a new medication into my clinical armamentarium is a very difficult process for me, but it's been made easier over the years utilizing a couple little tricks. The first is I realize I'm not in this alone. Right? There are wonderful mentors, mentees through the Society for Pediatric Dermatology that I can pick up a phone and ask their personal experience doing something that's new for me. More to the point of what we're doing here today at the American Academy of Dermatology. I could sit in the pre-AAD Society for Pediatric Dermatology conference and hear exactly from colleagues who've been doing this now for several years, either through a clinical trial experience or again, through their personal experience, learning about their safety and efficacy data, hearing their clinical pearls and kind of taking that home for me to use on my own. The example that I use is Dupilumab. When that first came out, hearing how safe and effective it was, but it was an injection to a child that required no blood work, seemed Looney Tunes to me. How am I going to get my patients to do this? And what am I doing to them that I have to be worried about? That prevented me from integrating that medicine probably at a point where I should have been a couple years sooner than I actually wound up embracing it. And at some point you realize, geez, you're almost behind the times if you're not using a medicine like that in your clinical environment, and now it's become second place for us to do that. So I think that only happened because of the experience that I had hearing from my colleagues and my peers through the society and through outlets like the AAD. I welcome any member of the Society for Pediatric Dermatology and any member of the public at large to use the Contact Us form that we're going to provide here for the podcast. Reach out to us with a show idea or a question, clinical of nature, whatever it might be, and we'll try to make that part of our next topic.